This seminar was conceived and planned long before the pandemic. In this sense, one could say that we were sort of ahead of the curve, because now with the pandemic, this question of trust in experts is part of the nightly news. But the reality is that anybody with eyes in their head could have seen, you know, in previous years, that this issue of trust in experts is a big issue, and it's going to be a huge issue, and obviously now with the pandemic as well. But we did want to do something different with the seminar. We did not want to begin from the sort of knee-jerk, can you believe it kind of reaction that is usually focuses attention on mistrust, and especially on the sort of more egregious cases in which the public is being misinformed, which obviously happens. But we wanted to explore what, to our minds, is a prior question, which is what is trust and under what conditions does it normally obtain? And so in designing this seminar, we didn't want to start from the assumption that trust in science and experts is the obvious default. Maybe things were different in some golden age prior in the past, but in recent decades, I think it's quite clear that it's not the obvious default. So it's far more productive and interesting to ask how, given all the reasons why people may not trust experts, how this precarious thing, trust, can be cultivated and protected. So we originally designed this seminar to focus on some issues that trust in science seems to be in the balance, like climate change, vaccines, environmental pollution in minority neighborhoods, etc. We will get to them later this year. But once we found ourselves in lockdown in the spring, it was very clear to us that the first topic we will need to address is COVID. And so, because this is indeed one of the most important political problems at the moment, is trust in experts during COVID. We have two more panels planned for this semester. On October 29, we will have a panel with social scientists, Rogers Brubaker, Steve Hilgartner, Andrew Lakoff, and our very own Zeynep Tufekci. And they will give their perspectives on the question of trust in experts during the pandemic. On November 12, we will have a panel on the question of the coming coronavirus vaccine and trust in vaccines. We will have Amanda Kahn from the CDC, our very own James Colgrove, Rupali Lemayev from Johns Hopkins, Jennifer Reich wrote a wonderful book about vaccines, and Jane Zucker of New York City Health. Today's panel, however, is about trust in models. We gave our panelists a prompt that summarized as briefly as possible our view of the crucial problem that needs to be discussed. But they are, of course, free to disagree with the prompt and take us in a different direction. This is the value of an open and frank exchange of ideas. Indeed, we want to learn from our panelists because they have real experience in this matter. We want to learn from them what they think are the important questions to ask. The prompt, nonetheless, is reprinted on the poster announcing the event. How should modelers communicate the uncertainty inherent in their models without undermining trust? What does it mean to trust a probabilistic forecast? Do models incorporating assumptions about public behavior need to be understood and trusted by the public being modeled? Should modelers try to influence the public and decision makers, or should we be worried that such attempts might backfire and lead to a loss of trust? I can also frame the question even more simply and connect it to the overall theme of the seminar. Modelers, and also other experts by extension, seem to be faced with a situation of damned if you will and damned if you don't. If they faithfully report all the uncertainties that their models cannot reduce, they run the risk of undermining trust in the model's results as a decision support. If they gloss or minimize these uncertainties, they run the same risk or worse. This is one reason why trust in science or in experts is not an obvious default, but sort of a precarious achievement that needs to be carefully cultivated. How do modelers and public health experts contend with this problem in their work? We have 5 speakers today. They are in the order of presentation: Matt Biggerstaff of the CDC, Ronald Scott Braithwaite of NYU Langone, Jennifer Nuzzo and Caitlin Rivers, both from Johns Hopkins Center for Health Security, and Jeff Shaman from Columbia University. I will introduce each one more fully in their turn. Once the last speaker is done, the floor will be open to Q&A. The audience should be able to see a Q&A feature on the Zoom dashboard. You can type your question at any time. Please indicate to whom the question is directed. You will be able to see other people's questions and vote on which question you want the panelists to address. When the Q&A begins, I will read the questions to the panelists in the order they have been upvoted. Unfortunately, because of the size of the audience, your mics are muted. Our first speaker is Matt Biggerstaff. He is an epidemiologist at the US Centers for Disease Control and Prevention. Prior to the epidemic, he led the CDC's influenza forecasting and modeling. In this role, he works to understand and evaluate how forecasting and mathematical modeling can complement influenza surveillance and inform public health response, including communication and influenza vaccination and treatment. Dr. Biggerstaff also works to develop methods to assess the severity of the influenza seasons and pandemics and lead studies to estimate the health and economic impact of influenza and influenza vaccinations. He has a Doctor of Science in Global Health and System Development from Tulane University. So, the view from the embattled Citadel down in Atlanta. The floor is yours, Matt.
Thank you, and thanks for the time today. Really appreciate having the opportunity to speak on this topic, which I think we all agree is really important. And I think the slides are going to be put up, hopefully, that I'll be walking through today. And really the theme I'm going to be kind of going over with my slides is we're trying to build trust in the products we're putting out by making everything sort of open and transparent and reproducible. So with the forecast we're putting out for coronavirus are sort of the inputs we're sort of using to drive our internal models or models across the government. We're trying to make that information as available as we can to the public and to policymakers so they understand where this is coming from. Next slide, please. So this just really wanted to first answer the question on how is CDC using modeling during the COVID-19 pandemic, and it's really to help CDC and our partners, and really a lot of the work of what CDC does is to empower and inform our partners respond to this pandemic by informing decisions about pandemic planning, resource allocation, and implementation of social distancing measures and other interventions. And given the time, I've chosen to focus on sort of two efforts to help this. One is short-term forecasting, and the second is our planning scenarios. Next two slides, please. So just talking about forecasting first, and then the next slide. So what are we doing? First, in the forecasting space, we have a primary collaboration with the University of Massachusetts at Amherst, but then beyond that, we're having inputs from across the country and the world with over, I think, 40 forecasts that we received this last week from different university or private industry or even personal individuals that are helping to forecast the COVID-19 pandemic in real time. What we're asking to help sort of prepare the country are forecasts for total reported deaths per week at the national and state level, newly reported deaths per week at the national and state level, daily new hospitalizations per day at the national and state level, and the newly reported cases per week at the national, state, and county level. And this represents, I think, an incredibly comprehensive forecasting system that has really only been in existence since really April. And that was with these total reported deaths. And we've added these outcomes throughout the pandemic as the needs sort of arose and the importance of those outcomes became apparent, and especially moving to the county level, which we started in July to help support more local decision making and sort of the detection of potential emerging areas of concern. On sort of the products we put out, we provide the individual forecasts from the groups, plus we make an ensemble which combines these forecasts together. And we've learned from the many years of flu forecasting and other vector-borne disease forecasting that sort of ensembling multiple forecasts together can improve the reliability and accuracy of forecasts, especially when we're talking about sort of the many geographic areas that we are now producing forecasts for at the national, state, and county level. Since April 13th, we've made all of the underlying data that's coming to us from these groups through the University of Massachusetts Amherst available publicly in real time, and we're making sure that data is archived and available. So that will help empower sort of anyone to kind of make accuracy assessments of their own or compare data among groups that are making forecasts to understand really how these forecasts fit into the ecosystem of forecast. And just want to highlight on my slides, you'll see sort of links, I think on every slide, and that's really where you can go find the publicly available information that I'm referencing in this talk. Next slide, please. So just want to kind of walk through what we're putting out and how we're also trying to communicate uncertainty, because that is one of the prompts we had. But each week we put out the forecast after we get them. They come in on Monday, and usually by Wednesday or Thursday, we have updated the CDC website with the sort of primary information from the forecast, and also tried to provide some communication messaging around that, you know, either saying if there's a high probability of increasing cases, decreasing cases, or if there's too much uncertainty in the trend to really make a statement. And we do that at the national level and at the state level as well. And on the top of this graph, you can see the national forecast with all of the models on the left. So you can find your favorite group there, including Jeff Shaman, who's on the call as one of these groups on the left. And that really we think is important to allow people to really understand where forecasts are in relation to other forecasts. We know there are a lot of policymakers or the public that may be using one forecast, and it's often difficult to know really how your forecast that you're using maybe relates to other forecasts. And so we think this information is important to help people really understand if the group they're using, where that might fit in the sort of universe of other forecasts. And then on the right, you can see the ensemble forecast along with all of the individual component models still outlines. You can kind of understand where the uncertainty from that ensemble is and how much does that capture sort of the universe of models that we're getting. On this, we're showing the 95% prediction interval in the light red, and then the 50% prediction interval in the dark red, along with sort of the median forecast. And the top is the new weekly death, and the bottom is the sort of cumulative death. So in one graphic, kind of understanding are our trends in deaths going up or down or remaining stable over the short-term period, and then really how much extra morbidity or mortality might accrue over this period. So in this sort of forecast that just went live, I think about an hour or two ago, you know, we had sort of an uncertain kind of trend over the next 4 weeks, with sort of a hint that it could be stable, but a lot of uncertainty, and sort of around maybe, you know, 4,000 to 8,000 deaths could be reported the week ending October 17th. Next slide. We also put this out in sort of a tweet every week to really try to also communicate this in a different way. And with the tweets, because we don't get a lot of space, we really emphasize the range that's going to be happening. So not trying to say this is the value, but really what do we think the value could be with good confidence. And we use our 95% prediction interval for that. And so going back to the tweet we put out on August 31st, we were saying, you know, there could be between 3,300 and 7,500 new deaths reported the week ending September 26th, which is the week we're in now, and that there should be with 95% confidence that at least 200,000 deaths should have occurred by this period. And unfortunately, we reached that milestone a couple of days ago, reaching the kind of 200,000 death mark. And so we are trying to sort of broach this through multiple streams, but also make sure there are records of what we're saying from these forecasts that can go be evaluated against later. And so that can hopefully at least empower the public and other policymakers who want to do the homework in this way, that at least what we're saying, does that actually become true, if I'm using air quotes that you may or may not be able to see, or not, and helping instill confidence in that way. Next slide. Also, the case forecasting started in July, so wanted to kind of walk through these quickly. These are, I think, also really helpful. They don't get the immediate attention, unfortunately, that deaths get, but I think they're really helpful to really understand what are the sort of leading trends that can tell us if we are potentially heading up or down, which then will have downstream impacts on mortality down the road. So similar setup, you can see all of the individual groups on the left. There's a lot of heterogeneity in these forecasts, and then the ensemble on the right there, as well as absolute counts, and then also put into rates, so people can kind of understand, what rate of new cases are we going to be seeing over this period, and does that put us in to sort of areas of higher transmission or lower transmission in that 4-week time window. And just a note about the 4 weeks, that is where we sort of have our confidence right now and how well we think forecasts can actually, the horizon that they're able to forecast. And so that's why we're truncating that to sort of not over promise what forecasting can do, and haven't been releasing sort of longer range forecasts that can go later because we're unclear really how those forecasts can perform as well. Next slide. Just wanted to highlight a couple of these county forecasts, not to dwell on them, but to show people that, even at your very local level, you can now go and look and see what many of the best forecasting groups in the country or the world are kind of saying about COVID cases in your area. And so I highlighted New York County or Manhattan for the home crowd that's hosting this, and then also DeKalb County, Georgia, where the CDC is located as well, to kind of show differences in, unfortunately, current incidents. We're not doing quite as well in DeKalb County as New York City is doing, and you can use the sort of rate comparisons for that, but also to highlight, even though our incidences are quite different, our trends are kind of stable over the period, but that is a little worse news for us in DeKalb than in New York City. But again, there's a large uncertainty window for both of these areas, especially as you get to these smaller geographies, and we always try to emphasize that both with these uncertainty envelopes and by showing the individual forecasts as well, to really emphasize that there's a lot here that's uncertain, especially at these small levels. Next slide. And then I won't dwell on hospitalizations, but it's our least robust forecasting system. But I think we are bringing these and wanting to publish them in real time, because hospitalization forecasts actually are potentially one of the more useful forecasts, because they do help, I think, with short-term resource planning in the healthcare sector. But there have been sort of numerous challenges in this space, including sort of what's the gold standard data, and it's being reported quite differently by state if they even, if they're reporting hospitalizations on certain time points. But that doesn't keep people from sort of using these forecasts to guide decision making. And so we think it's really important to still show how these forecasts relate to each other, but we've chosen not to make an ensemble of them right now until we really can understand how well these forecasts are doing compared to observed data. So we know if our ensemble is really performing in the way we want it to. And so we've made a decision to not make an ensemble here, so we're not giving sort of the appearance like we do in the other ensembles, that we have some confidence in that until we can assess sort of how this system is actually performing, but still trying to empower people to understand how a forecast they may be using, how different it may be from other forecasts for the same outcome. Next slide, please. And then just, how are we actually trying to be transparent with what we are forecasting? And if people really wanted to know how are these forecasts ending up in an ensemble, why is a forecast not ending up in an ensemble? And so every week, first, we sort of have very clear guidance for teams that are wanting to make forecasts, sort of what's the gold standard, what's the format these forecasts need to be uploaded in, when are they due, and these are things we've learned from our many years of flu and vector-borne forecasting, that just having a clear ask, so what do we think is useful for public health, by writing it into these really, I think, is transparent in terms for modeling and allows the forecasters to really know what we can use for public health decision making. But I also think it lets people know what we're really trying to do and forecast, which can be difficult if you're not clear, what data sets are being used or really what we're after. And then it's also, I think, really important for us for people to feel like our ensemble is transparent, and the groups that are being included or excluded are really for objective criteria, and there's no sort of odd finagling going on behind the scenes to make numbers that aren't replicable. And so every week you'll see sort of an ensemble meta data table that tells you who's in it, And if they're not in the ensemble that submitted, then what was sort of the flag that excluded them? And that information is also provided back to teams so they know why they aren't included in that. Next slide, please. We also work with the teams that are making these forecasts to really try to understand the methods that are going in. And so there was part of the prompt, you know, how do you actually explain the assumptions? Is it important and can that reduce the certainty in the forecast? But we work to at least try to summarize these in as plain language as possible, which is a challenge. But so people at least are sort of understanding, you know, trying to understand what are they making, what assumptions about social distancing are they making. You know, we try to group models into those categories because that was sort of a main stratification we saw initially in forecasting. One of the challenges we had to work through in a space where there are no true constants, since we can change our behaviors based on these forecasts and have done that. So we want to be explicit first and put those models into those groups of those who do make assumptions about the future and those who don't. And then you can kind of click and really try to learn about these individual models if you're interested in kind of diving in. And we have links back to every page for the groups making these, where they also sometimes provide code if they do that for their forecast. You can really try to learn about the kind of ecosystem we have for forecasting if you're interested. Next slide, please. And then sort of this building trust, we really have worked hard. I mean, on those sites that I have already linked, you can go back and find all of the raw forecast data on the CDC sort of main sites that were linked early, on the GitHub site and the Zoltar site that were linked later. And then we also have these visualization platforms where you can really go back in time with what was observed versus forecasted, not only for the ensemble, but for the individual models that had been submitted as well. And so you can kind of decide if you're going to evaluate for the state you're in, and maybe you have a model there that you're working with as a state health official, or you're just a member of the public and you understand how the ensemble is doing compared to other individual models. You have the sort of power to do that with just pointing and clicking on this data tracker. And right now it just has cumulative deaths, hopefully today at 4. Incident deaths hopefully have gone up. I wasn't able to check if that happened. And in the next few weeks, the case forecast should be on there as well. And then that will also provide it at the county level. And so really, you know, you don't need to have any sort of coding expertise. This is all point and click. And you can see there's an icon for a table. You can also pull the data in a little more graphical format that way if you would like. And you can see the forecasts there that were made, I think, about 4 weeks ago, because this covers sort of the observed horizon. In 2 weeks, we're showing, you know, the ensemble was predicting a median of about 183,000 deaths, and the actual was about 182,000. So it was about a 600 absolute error difference, but you can go through and really see how it's performing with sort of the median, and also the confidence intervals are provided as well. Next slide. But also we know that, you know, people want to sort of understand this in a little more scientific way. So we've worked hard and are continuing to work to try to put things out on preprints that are more scientifically assessing the performance of the ensemble initially, because that is our main way we're messaging at CDC. And so we want to make sure the science is robust and the evidence is robust for that. And so we worked, I think this data goes mainly through late July to assess the accuracy of that ensemble with standard, you know, mean absolute error metrics, but also considering you had a prompt about probabilistic forecast, we also are huge fans of probabilistic forecasting, and I know Jeff Shaman will probably echo that as well during his talk, as he's sort of the father of pushing that along. But we're sort of measuring the performance of these ensembles with those 50 and 95% coverage intervals we show against how often the observations are actually occurring in that window. And so you want, you know, your 50% coverage to be observed at least around 50% of the time, and your 95% coverage to be observed 95% of the time. So you have confidence that that window means something. And so those are some of the metrics we're performing and putting out as well. And we look at those internally every week using the same methods that are described in this paper to make sure there are no red flags occurring. And we actually use the evidence from this paper to sort of change how we made the ensemble. It's a little technical and I won't go into in this talk, but we wanted to document that as well. And you can see the ensemble is, especially the 95% coverage, is matching data around the time we would expect, and the 50% is a little conservative. So more often the data is falling in that 50% interval than you would want in a perfectly calibrated forecast, but we're okay at least with an error on the too often side than too little. Next slide. And then I just wanted to talk briefly, because I think I'm getting close to my 20 minutes here, or 15 minutes, just our planning scenarios. And so next slide, this was just a way, and if you go on this site, you'll see a whole bunch of inputs under different scenarios for important parameters for COVID-19 that can help with modeling, including infections that are asymptomatic, infectiousness of asymptomatic relative to symptomatic, the infection fatality ratio, the R naught. We really want to be transparent with sort of what inputs are going into sort of any internal models that are driving policy or understandings of COVID-19. And so you can go here and see what our sort of uncertainty ranges are and what our best guess is, both for what's current there, and we also wanted to make sure we don't erase this, and so we keep archives of what we've had in the past. And this was really spurred on because there were some media stories a little early on in this of these sort of CDC planning scenarios that were sort of not transparent, right? They just were sort of leaked out with some screenshots, and we wanted to work to make sure the public and people knew what was driving our modeling. And so we worked to get all of this up with a ton of documentation of what these references are actually going in to that. And so if you go onto this page, you'll see probably half the page is sort of the evidence and the rationale for what we pulled out of those papers. Next slide. So just in conclusion, modeling is integral to the CDC response, and CDC and the UMass Amherst, plus this whole ecosystem of universities, private companies, and individuals, built a COVID-19 forecasting system in real time that forecasts important outcomes at the national, state, and county level, provides transparent forecast targets, structure, data, and methods, and then allows for the independent forecast comparisons and assessment by the public, researchers, and policymakers. And so we hope the way we're building this at least creates a defensible, transparent system that can instill as much trust as possible in something. You know, I think it's actually really hard to do this in other forecasting enterprises. What we're doing here, you know, it's hard to go back and look at hurricane tracks versus what was forecasted in an easily clickable way. And so I think we are doing a lot here to try to empower people to have confidence in the forecast we're putting out. And then we also want to make sure that people understand what assumptions are going in just for our other scenario and planning models as well, and want to be transparent there as a way to kind of improve trust in federal modeling for this response. And with that, I am happy to end and then take questions at the end. Thank you for your time.
Thank you, Matt. I'm not sure if people can hear me or see me, for that matter.
I can hear you. Yeah.
Okay, great. So let me remind the audience that I'm sure they have a lot of questions for Matt for a fascinating talk. Let me remind you that you can write your questions in the Q&A feature at any time, and we will take the questions at the end in the order that they have been upvoted. Our second speaker is Ronald Scott Braithwaite. Braithwaite is the Chief of the Division of Comparative Effectiveness and Decision Science in the Department of Population Health at NYU Langone. He's a professor of population health and medicine. He's past president of the Society for Medical Decision Making, an international professional organization devoted to decision modeling in health. Dr. Braithwaite is an accomplished investigator in the field of decision science, quality, and cost effectiveness, focusing on policy-relevant research to optimize quality and value in healthcare. Scott, please, the floor is yours.
There we go. It's better unmuted. It's great to be here talking to all of you, and I hope that we can think about some exciting things together. This is more a presentation, not so much about what we've been doing, but about what should we be doing. And it's entitled, Can We Do Better Than Squiggles? Should We? I think we already saw that many of us are doing a lot better than squiggles. I love the ensemble forecasting in the last presentation. Please advance the slide. Okay, disclosure, I'm not an expert in traffic, weather, sports, or financial markets, but maybe some of you are. And if you are, you can make this more enlightening. Next. Okay, so this is a question that I ask myself on a regular basis, and so it was wonderful to have. It's wonderful to have this this event today to really talk about this with other people. Can health modelers learn from other domains in which probabilistic predictions occur regularly? And occur regularly and are important. And I mean, one way to assess this is just to turn on the news. And if you have on a news station, what are the very frequently updated bulletins about? Traffic, weather, sports, financial markets. Not health, although health is becoming more a daily forecasting event in the COVID era, but I wouldn't say we're up there with traffic, weather, sports, and the markets, but who knows? Next slide. Okay, but what are themes across these different domains when you're trying to predict something and when there's clearly an increased precision that comes about if you can make and communicate your prediction in a probabilistic way? What is similar, what is different? So here is one possible way of deconstructing that. Does the prediction vary over time and space? And or is it multifocal? If the prediction varies over time and space and is multifocal, communicating probabilistic information becomes harder. It's not simply an event. Does the prediction involve distinct domains of importance? So for example here, do you need to predict where a hurricane will go? Or do you need to think about rain in low-lying areas? Do you need to think about a storm surge? Do you need to think about wind? Communicating probabilistic information becomes harder if it requires distinct domains or dimensions. Third, are expectations known, presumed, or indexed by an existing market? Then the information that needs to be provided by the model can emphasize deviations from usual performance because usual performance is baked into expectations or what everybody is thinking about regularly. So for example, you don't need a model to tell you that during rush hour, there's going to be a lot of traffic. However, if the model could predict when there would be deviations from a lot of traffic during rush hour, that would be very helpful. So if expectations are known, communication probabilistic information becomes easier because you don't have to communicate the norms, you just have to communicate the deviation. Okay, fourth, is a prediction for consumption by experts rather than by lay people. So the authority may have specialized expertise or skills in interpreting probabilistic data, and that could make it easier, but sometimes the experts are focusing as translators for lay decision makers that are further up in the chain of command. And if so, what if you can do the translation better than they can? Maybe you shouldn't think that, but many of us do. And then finally, is finely grained probabilistic information necessary for decision making? So if it is, then the value of partial perfect information is high. We'll get into what that means in a second. And simplifying is not an option. So communication becomes harder because it's more important to do it with great precision. On the other hand, if finely grained probabilistic information is not necessary for the decisions that are based on it, then it is not as important to communicate the full degree of the probabilistic distribution. Next slide, please. Just to acquaint those of you who are not familiar with value of information theory. So value of information theory is used to quantify benefit from additional information or greater certainty regarding the existing information. So here value is the magnitude of incremental health benefits and or expenditures that are foregone. The idea in non-mathematical terms, if better or more helpful decisions are enabled by additional information, then that information is higher value. But if that additional information does not impact decisions, then that information has lower value. And this comes in a variety of different applications. So value of perfect information would come from eliminating all certainty. Naturally, that never happens. So what we typically work with is the value of partial perfect information. So the value from gaining more statistical certainty. It's always possible to know more about anything, but when is it important to do so? This is one way to address that question. And you can go backwards. You can think of it in terms of a communication context, and you can say, well, instead of asking how important is it to know more information or to have greater precision about an information estimate, you can say, well, how important is it to preserve the level of detail and precision that I think is there? So a possible heuristic could be, it's okay to simplify a probabilistic estimate if the value of partial perfect information lost during simplification from communicating less statistical certainty is small. But then this presumes that there is agreement on decision alternatives and the important outcomes. Next. Okay, so where does value of information theory impact what we're talking about today? Well, let's say it's arguably important to ask, is uncertainty of information de-emphasized even if it is important for decision making? If so, that's a bad thing. However, if uncertainty of information is de-emphasized when it is not important for decision making, this is not necessarily a bad thing, or is it? It may be favored by duty of beneficence. The world might be a better place if you don't unnecessarily obscure things by having levels of detail that aren't warranted. On the other hand, it may be disfavored by professional duties or transparency. It would be interesting to know what ethicists think about this issue. But there are already quite a few of us on this panel, so let's continue. Next. Okay, what are themes across these domains? Weather, traffic, health, sports, financial markets. Well, let's start with weather. Does the prediction vary over time and space, or is multifocal? Yes, that certainly is true of weather. It varies over time and space, and many different things can happen at the same time. Does the prediction involve distinct domains of importance? Well, yes, it does. Think about a major storm. The wind can be benign, but the storm surge can be terrible, or vice versa. Are expectations known, presumed, or indexed by an existing market? Not really, no. I mean, other than these boutique markets that spring up regarding particular storms, so there isn't really a futures market that would channel the wisdom of a great many people into this. So that doesn't apply. Is prediction for consumption by experts rather than lay people? Yes and no. Lay people certainly are interested, but experts are interested in too. Experts may be interested in deciding whether they have to close a hospital because of a storm surge, which is something that happened here in New York. Is finely grained probabilistic information necessary for decision making? In the big storms, yes, it is very important whether your city is hit or not. It probably is more important in the spatial realm than in the time realm, but that also is arguable. Next slide. How about traffic? Does the prediction vary over time and space, or is multifocal? Yes. So that makes it harder. And keep in mind that although on a news station you're likely to get a traffic nowcast rather than a forecast, think about the burgeoning forecasting that's going on. Say when you go to Google or Waze, and you think, well, it's factoring in and putting together the average speed of vehicles on your projected route right now, but is it also considering what's going to happen by the time you get there based on historical averages? Is it also taking into consideration your driving habits and how your driving habits may not matter at all if you're stuck in traffic, because everybody's stuck in traffic. But if you're on a freeway, they probably matter quite a bit because some people drive faster than others. Does the prediction involve distinct domains of importance? I don't think so, although maybe you can persuade me otherwise. I don't know. It seems like if you're in traffic, you're in traffic, and if you're not, you're not. But probably traffic engineers see much more nuance in this than I am, because I'm a health person, not a traffic person. Are expectations known, presumed, or indexed by an existing market? Not as far as I know. Is the prediction for consumption by experts rather than lay people? No, it's by and large lay people as far as I know. Is finely grained probabilistic information necessary for decision making? Well, yes, it is. And here it's interesting that we don't get it. So, for example, when I'm trying to figure out the best route, I might have to be at a really important talk like this one in 20 minutes. And so I would actually favor a route that I knew would get me to my destination in 18 minutes. That is, if I did have to travel. Then a route that on average would do it in 15 minutes, but with a 95% spread of 5 minutes to 25 minutes, because it's more important to me not to be late. So maybe that'll happen in the future. Hasn't happened yet. Next. So what about in sports? Does the prediction vary over time and space? Multifocal? No, it's an event. It does, it happens, and there's a score. Doesn't involve distinct domains of importance. Expectations are known and presumed by many markets. Things are factored into spreads and betting and whatnot. Is a prediction for consumption by experts rather than lay people? No. Is finely grained probabilistic information necessary for decision making? It probably depends on the decision, whether you're gaming or not. So yes or no. Next. For financial markets, many of the same parallels apply as with sports, because the decisions are by and large financial, and they have similar they have markets, and a lot of the added value comes into doing better with those markets. Next slide. How about health? That's what brought us all here. Does the prediction vary over time and space, and is it multifocal? Yes. Does the prediction involve distinct domains of importance? Yes. I mean, even with COVID, you could say, well, if I die, I don't care what I died of. But above and beyond cases, infections, and deaths, there are also issues of strain on hospitals and health systems. Are expectations known, presumed, or indexed by an existing market? No. Not as far as I know, although maybe there's one that I just don't know about. Is a prediction for consumption by experts rather than lay people? Yes and no. That really is the crux of why we're here today. To what extent are we working? Should modelers be working for experts, lay people, and should results be understandable? Is finely grained probabilistic information necessary for decision making? Sometimes yes, sometimes no. And I'm not sure modelers think about that a whole bunch. So for example, if you're going to have 20,000 deaths or 25,000 deaths, you might end up making the same decision regarding closing or social distancing. So sometimes statistical precision may influence the decision. Sometimes it may not. So it's yes or no here. And that's part of what is making today's discussion interesting and exciting. Next. Okay, so if you put these together in a sort of schematic, so you got weather, traffic, sports, financial markets, and health, and you ask, well, prediction in the health domain, which of these domains is it more like, which of it is it less like? Seems to me more like weather, in that there are distinct predictions across time and space, and there can be separate foci. There are different domains within the larger prediction. There isn't really a market or some sort of group decision-based unit to help you. Experts are interested, and lay people are interested too. And finely grained information is often necessary to make good decisions. Next slide, please. So let's think about, so being health people, let's think a little bit about weather. And I appreciate that the previous speaker mentioned the hurricane. Well, and also mentioned how, does anybody go back and see what happened with the prediction. So this is this was a prediction by NOAA regarding Hurricane Sandy, what became Superstorm Sandy. And this was from Friday, October 26th, so it was 3 days before it hit. And here you have a prediction. And well, what do you notice? I mean, the first thing you ask yourself is, was it accurate? Was it not accurate? Okay. I mean, New York City is right, kind of in the middle, so it was accurate in that respect. But which probabilistic information did they convey, and which didn't they convey? So you can see the cone of uncertainty. So clearly, a lot of uncertainty regarding space was conveyed, and was conveyed very explicitly. And I may be wrong about this, but I think it's about 2/3 within the cone of uncertainty, but I could be wrong. It's not 95% confidence interval or even interquartile range. So that's what that is. Time, so clearly there's uncertainty about time too, but uncertainty in the time dimension is not represented here. And uncertainty regarding strength, there's uncertainty regarding strength, but it really is represented in a very basic way in that you're either a sub-hurricane or hurricane. There are versions of these that have estimated 1 versus 2 versus 3, but we don't get that here. So there's clearly some compromise being made. There's a lot of probabilistic information, but there's an implicit decision to have most of the probabilistic communication burden go to space rather than time or strength, perhaps because there's an implicit awareness that that is the probabilistic information that has the highest value of partial perfect information. It's most important for decision making. If you're in the city and the hurricane's going there, you want to get out of the city. If it comes maybe 8 hours later, well, you want to be out of there long before then anyway. Next. But it's supplemented by a lot of other things. So here we're drilling down on the domain of wind speed. And so here again, emphasis is on space, and emphasis is, and there's explicit probability about where you, if you are in a particular point, you can see whether you're purple or green or yellow. So that indicates, and this is a directly probabilistic forecast, and that the probability is right down there indexed to the color. So you get the probability of having tropical storm force surface winds. Now, keep in mind that what's being compromised here in order to have probability conveyed on one dimension, well, you just know if it's going to be tropical storm force. You don't have varying estimates if it's hurricane force, category 2 force, category 3, etc. And also, time is condensed. So this is over a 120-hour time period. So it's almost certain that there would have been more detailed estimates that are more finely grained by time, but that's not shown. Next. And here we have the storm surge. Well, this certainly ended up being very important. So here you have a particular facet of the hurricane, hurricane damage. And here again, space is highly conveyed. We don't really have probability here. So there's some implicit probability threshold over which the surge would occur. But we do indeed have the surge. Time is put together. We don't have specific times. It's over 77 hours in this particular case. Advance the slide. Okay. Before we get to health, I want to pause and just ask you, okay, well, those were forecasts for Hurricane Sandy 3 days before it did a lot of damage in our current area. A lot of great probabilistic information was available. Was it conveyed? Was it conveyed well? What ideally would have been conveyed that wasn't? Or what was conveyed that maybe wasn't all that important? It's fun to think about that. And now, okay, let's think about health. So here we have a dashboard of I mean, these are not really estimates so much as historical data, but this same format is often used for predictions as well. So there is some granularity by space. There isn't a lot of there isn't a lot of probabilistic information. It's more what is the highest likelihood of happening in the future. But if you're going to have spatial granularity, how much temporal probabilistic information can you have? You can have a good bit, as evidenced by what we just saw in those fabulous ensemble graphs, but you could potentially even have more than that. Would you want that? Next. Here is a graphic from our group, and we're thinking together with various authorities about education plans and school closing and whatnot. And so here we're doing a very primitive job of wrestling with probability, just having probability in one dimension, and having different lines, not having really nice spreads that are visibly indicated. Perhaps we should, but in this case, the people who are looking at the graphs and making the decisions don't necessarily want the spreads, and they communicated that to us. And I think, again, implicitly, the issue is to make the decision, is the probabilistic information giving sufficient value so that the additional information is worth the cognitive complexity? Next slide. So concluding questions. Are squiggles good enough? No, probably not. If not, what should there be instead of squiggles? Should it be something like what we just saw with the ensemble spreads? Should it be more than that? Do we want something like a cone of uncertainty? But it would need to be much more topologically complex, because we're not talking about one single storm, we're talking about multiple outbreaks. But there could be. You could have multiple cones that come and dissolve. Do we want something else? Well, I really don't know. And since I touched upon a lot outside of health, I may have said some things that were really misguided or wrong. So the enlightening discourse is to begin now. And I'm excited about the idea of thinking more about these ideas with all of you.
Okay, thank you, Scott. Hopefully I can be seen and heard. Thank you for this fascinating talk. I do hear that, you know, TV stations are now starting to hire epidemiologists for the segment instead of the weather report. Our third speaker is Jennifer Nuzzo. She is a senior scholar at the Johns Hopkins Center for Health Security, associate professor at the Department of Environmental Health and Engineering and the Department of Epidemiology at Johns Hopkins Bloomberg School of Public Health. She's also a senior fellow for global health at the Council for Foreign Relations. She's an epidemiologist by training, and she's also the lead epidemiologist for Johns Hopkins COVID-19 Testing Insights Initiative, housed within the Johns Hopkins Coronavirus Resource Center. Thank you, Jennifer. Please go ahead.
Great. Thank you so much for the introduction and for including me in this interesting conversation. So I'm going to take a step back a little bit and just talk about what underpins models, and that's the surveillance data that we have. I'm going to talk about this because when you get to the question of, you know, how much should we trust it and how are these models used, I think it's really important to understand kind of what underpins the models, you know, the quality of the data that we have upon which we perform our modeling. And public health surveillance is a key input to many of the models that we've seen used and talked about during COVID-19. We've seen models generated to try to explain the spread of the virus, to evaluate the impact of various different control strategies, to make projections about, you know, ultimate outcomes, things like hospitalizations and deaths. And all of these efforts rely on having accurate case counts, dates of onset of infections, and, you know, our ability to kind of identify one generation or discern one generation of cases from the next. So if we're going to talk about how to use these models and how much we should trust them, I think we should have a conversation about the accuracy of the public health surveillance data that underpin them. So that's what I'm going to talk about mostly in my remarks. Next slide. So modeling has played a highly public role since the beginning of this pandemic, and there were efforts very early on to try to take the observed case numbers that we were seeing and make some estimates about how quickly it was this virus was likely spreading and how deadly it was. There were a number of questions that were being addressed, including, what proportion of the world would likely become infected, et cetera. These are highly relevant questions, and it's quite necessary to use modeling in order to try to address these questions. But it's a very difficult thing to do, particularly at the beginning of a pandemic when we're just standing up surveillance. And in the case of COVID-19, what we're talking about is standing up surveillance for a completely new virus. So there's a need to get new tests, and it's just a much harder endeavor than were we talking about modeling a disease for which we have seen for decades and very much understand patterns in usual surveillance. So the early estimates are, quite understandably often challenged by just the inadequacy of the early surveillance as we are trying to stand up surveillance. Infectious disease epidemiologists understand this and recognize that those early estimates are likely to change, but it's difficult to explain these uncertainties to the public that is quite understandably hungry for information that's going to tell them, how bad could it get and how worried should I be. What I'm showing here on this slide is a tweet. I didn't identify the person who tweeted it because it's irrelevant, but many of you probably have seen this tweet. It's somewhat infamous. It was reacting to some of the early estimates of how fast the disease was likely spreading. And while the concern that was occurring at the time was, quite real, I think the nature of the tweet kind of speaks to how hard it is to both talk about what we're finding in a way that adequately conveys the concern, but also leave open the idea that these estimates could be wrong, they might change, and also not wanting to kind of unnecessarily increase anxieties, particularly when at that point there was probably not much that individuals could do. Next slide, please. It's particularly hard to explain how transmissible a virus is to a non-technical audience, and there have been various attempts to do this. I'm showing here a scene from the movie Contagion. If you haven't seen the film, Kate Winslet, shown here, plays an epidemic intelligence officer from the CDC, and in this scene in particular, she's trying to explain how scientists initially estimate how quickly a pathogen is spreading. I wanted to show you this film just because it was probably one of the first times I saw in the movies someone explain, a reproductive number, that concept. But also Columbia University plays a supporting role in this film. And actually, if you were to zoom out on this scene, you'd see your own Ian Lipkin as one of the extras in the film. He was an advisor to the film and actually made it into this particular scene, which was kind of neat. Next slide. But this concept, basic reproductive number, which they tried to do in the film, is, I think one of the harder things to explain, in part because people sort of look for absolutes, and it's hard to kind of get across the fact that this estimate can be highly contextual. It can vary by the pathogen. Sometimes we talk about it as though this is a fixed parameter of a particular pathogen. It's not. It can vary according to the population in which the pathogen is spreading, and it can also vary according to the control measures that are being applied. So we expect to see this change over time. And the way that we try to come up with this estimate is, we have equations that we could use to calculate it theoretically, but really what we wind up doing is deriving it from the surveillance data that we have. We have one generation of cases and we have the next generation of cases, and we try to estimate what number gets us from one to the next. And that is easier to do when we have better surveillance. And in the beginning of a pandemic or even an outbreak, when our surveillance may be not yet where it needs to be, we may be missing cases. And so our estimates of how you get from one generation to the next can, be not quite accurate. And that's why that's another reason why these numbers change over time. Again, there's a lot of nuance here, very difficult to explain. Next slide. So I put that as sort of the background, just to say, if we're going to talk about modeling in the context of COVID-19, we need to talk about surveillance and the quality of the surveillance. So what is the quality of the case surveillance for COVID-19? I'm going to just spend the next few slides just telling you what I think we're seeing today with respect to COVID-19. And what I'm showing in this particular slide is the global COVID map that my colleague Lauren Gardner created relatively early in the pandemic. Lauren actually created this map as a way to help gather data that she and her team could use to inform their own modeling efforts. But it has since become a global resource that provides, in my view, one of the most comprehensive and up-to-date kind of look at global COVID-19 case reports and trends. Governments and news media outlets across the world are using this site that Lauren created to track the spread of COVID-19, and I give her a tremendous amount of credit. She actually this week was just named one of the, by Time Magazine, one of the top 100 most influential people, and I think it's a well-deserved honor because this was quite an endeavor and a tremendous amount of effort and work on her part to kind of manage all of the work, as well as stress of when you have literally billions of eyeballs on a product that you've created. But what the dashboard tells us today is that we have seen so far upwards of 31 million cases of COVID-19, and we're approaching about 1 million deaths worldwide. Next slide. The majority of the cases reported to date have been in the United States. We are, as of today, approaching 7 million cases, and just this week passed the grim milestone of more than 200,000 deaths. I'd also like to call your attention to the bottom right-hand corner of the slide, where you see the number of cases being reported in the United States per day. We are currently seeing more cases per day than we experienced in the spring, before much of the United States shut down to try to slow the spread of this virus. So one would probably see this and infer that more people are getting sick now than they were in the spring. And I believe that very much to be true, but to know this, we can't just look at the case numbers. We need to have more information in order to interpret these numbers. And I will come back to that in a second. What I'm going to show you next, if you could go to the next slide, is that we are seeing similar increases in cases elsewhere in the world, including, quite unfortunately, countries that had previously brought their case numbers down and had been keeping them down for quite a while. This week, the World Health Organization and the European Centers for Disease Control issued a very stark warning about a concerning rapid rise in cases in Europe. And some of the countries that are now experiencing rise in cases are seeing case numbers that rival, or in some cases exceed, what they saw in the spring. Many of these countries responded quite quickly and were able to bring their case numbers down and keep them down for quite a while through shutdowns and various other control measures. But after sustained declines, they are now seeing rather concerning rises. So France, United Kingdom, and Spain, just shown here, as you can see, their case numbers are rivaling their pre-shutdown levels. Next slide. So coming back to that question, does this mean that the rise in cases that we're seeing in the United States and in other countries means that more people are becoming infected? So again, I think the answer to this is clearly yes, but in order to answer this question, we need more information than just the simple surveillance numbers. After my colleague Lauren Gardner created the global COVID map, it became increasingly clear that in order to help us interpret the case numbers that she was gathering and the trends that her dashboard was showing, we needed to also collect other information that would help us interpret those data. So when we're seeing things like deaths being reported by countries, and the next question is, are there differences in the age structures of the countries that would make it possibly explain why one country would see a certain percentage of cases resulting in deaths versus another country? That's, I think, an important contextual factor that may not be quite obvious in the just the raw case numbers, but very much is needed to help us interpret the case numbers. And then we also need to understand the quality of the surveillance. And in the spring, it became increasingly clear that in order to understand the case numbers that we are seeing, certainly in the United States, but also in other countries, we needed to understand the extent to which US states and other countries were conducting tests to find and diagnose SARS-CoV-2 viral infection that is associated with COVID-19. And so as a result, we stood up another component of the site where the map is housed. It's part of the larger Coronavirus Resource Center, and it's the Testing Insights Initiative, which I'm a part of, to track testing, both in the United States, but in other countries. Most of our work is in the US, but we do, as I'll show you, track testing. And what we've seen through our testing tracking efforts is that the testing environment in the US has changed dramatically since the spring. As you can see on this graph, in sort of the pale orange bars, the numbers of tests being performed per day in the United States have expanded dramatically. And there was a while where the president was trying to explain away the rise in case numbers as a result of this increased testing. This idea that, you know, we wouldn't be finding as many cases if we weren't doing so much testing. And it's true, we wouldn't be finding as many cases if we stopped testing for the virus, but what the data that we are tracking shows us is that this rise in cases that we're seeing is not necessarily just because we are testing more. And one of the ways that we know that is we look at something called test positivity, and that's basically the percentage of tests that are performed or people who are tested that come back positive. And because test positivity at various points has increased, what that tells us is the spread of infection is outpacing the expansion in testing. We also track this on a state-by-state level, and what we have found within the US is that how states are looking for cases, how wide of a net they're casting in order to try to diagnose infection through testing varies considerably. And this is just really important for us to understand. When we see X state has Y number of cases, we need to understand the process by which they are finding that case, those cases, and how aggressive they are in trying to look for them. Next slide. Just to show you this, the variability that exists throughout the world. This is just a plot of test positivity versus test per capita across the whole world. That kind of large circle that the red arrow is pointing to is the United States. The size of the circle is supposed to indicate how many infections we're seeing. But what this shows us is that the amount of testing that countries are doing, as well as the impact of that testing, how many what proportion of the testing that they're doing is identifying infections, that test positivity varies considerably. And so if you have a country that has a very high test positivity, as some of those on the top of the chart, what that means is that there's probably a whole lot of infections that are occurring out there that they're missing. So that should be something to hold in your mind when you look at the case numbers from those countries. Next slide. Since starting this effort, both on the case side through Lauren's efforts and on the testing side, I think one of the things that's become increasingly clear is that the absence of data standards makes it really hard to track these things and to compare data between countries or data between states. You know, when you speak to scientists, it seems like fundamentally clear. Of course, you want to make sure that you are measuring the same thing if you're going to compare them. But the reality is surveillance in the United States, and you know, frankly, when we compare countries for the virus and for testing, it's sort of the wild, wild west in terms of how we are reporting on cases and tests. It's a little bit better with cases, but still in the United States, there are differences in how states count and report cases. There's a category called probable cases, which means that there doesn't have quite the same amount of evidence as a confirmed case, and in an ideal circumstance, those would be reported separately. Some states don't even report probable cases, and some states do, but they lump them all in as cases, so it's hard to understand what proportion of the total case counts have been confirmed. This just makes it really hard to know if we're comparing apples to apples, and ultimately I think just, you know, leaves questions in the data. Not to say that I have any reason to doubt that we are, you know, grossly not counting cases properly, but it also just makes it challenging when you're trying to do more nuanced analyses of the data that you have. Next slide. We've also had other data problems that have been reported and reported publicly. And when we talk about trust in models, we also have to recognize that these data challenges are playing out on the public stage, and people hear about this, and this can influence their belief in what to believe or not. So here's just one example. State of California at some point discovered that there was a problem with one of the servers that was reporting testing data to them, and suddenly they discovered that there were about 300,000 test results that they hadn't previously counted in their testing and case numbers. Honest mistake for sure, but it's just a challenge, and I think it speaks to somewhat maybe the inadequacy of our public health informatics here in the U.S., but certainly if you can imagine that many other countries are now able to test for COVID-19, but never previously were able to conduct PCR tests to look for a virus like COVID-19. You can just imagine the surveillance challenges that exist throughout the world if it's hard for a state like California to be able to count cases fully. Next slide. Another thing that's played out quite publicly is delays in testing. I believe this is actually a headline from New York. New York has been sort of the center of reporting on testing delays, but it's certainly a problem that exists throughout the United States. And in my belief that the reporting on how long it's been taking to get test results back, as well as people's just individual experiences and hearing from friends and neighbors how long it takes to get test results back, has contributed to, I think, a downtick in testing, in the sense that I think there's a sense that, why bother? It's going to take too long to get the results anyway. And this clearly is going to influence our surveillance, where you may have infected people who possibly should be tested, but don't bother to because they don't see value in it. So that's just yet another surveillance challenge. Next slide. And then another rising issue, you may have also heard in the news about a push to kind of retire, or not retire, but maybe supplement the kind of lab-based, was probably considered gold standard PCR-based testing for SARS-CoV-2 virus in favor of rapid tests that, rather than look for the genetic material of the virus, look for a protein on the surface of the virus. It's called antigen tests. These tests, I think, are going to be enormously useful in a number of settings, but there are deep concerns that because they are not being performed in laboratories, they may be performed in places like nursing homes and schools, and possibly, according to some views, the home. I mean, I think some people are really pushing for these tests to be ubiquitous. There are deep worries that that will not be paired with efforts to capture the test results and the fact that the test was performed in the first place. And there are deep worries that our surveillance for the virus, and it's not just this virus, the rise of rapid testing for other pathogens like foodborne infections has contributed to an erosion of surveillance, meaning we are counting fewer cases because the results are simply not being reported to public health authorities. So we very much have to, I think, be mindful that this potentially is on the horizon. It may actually be already happening, and maybe explain why there's been a drop-off in the testing numbers reported in the United States as of late. We don't know for sure, but something that we should certainly be mindful of. Next slide. And finally, I have just 2 slides here to end, which is I have to explain to you all of the technical challenges in surveillance. And I've done this as a way to show you that if you're going to lift up the hood on models and understand what populates them, then we need to understand the strengths and weaknesses of the surveillance data that models depend on. But when it comes to the question of trust, even if we have addressed all of those technical challenges, even if we had the best surveillance systems in the world, there still is the whole role of politics and conspiracy theories and trust and how people view the agencies that are involved in this work as to whether or not they're going to believe what they hear. And there have been a number of, since the beginning of this pandemic, but certainly as of late, just a number of kind of conspiracy theories. You can't even call them conspiracy theories because in some cases they're being advanced by high-level political leaders, but open questions about the quality of surveillance data that, in my view, go beyond just an honest question of, can we tweak it here and there, which is, I think, more where we are, to, a flat-out rejection of the numbers themselves. And so you hear things like, people's belief that hospitals are over counting deaths because they want to be paid more. You know, high-level political officials have suggested this is true. Then there's the political fight between agencies that have, you know, essentially resulted in interruptions in key surveillance metrics like hospitalizations. And when people see this and they think that if there's this political fight happening, then it may cause them to just not believe any of the data that they hear because they think the whole thing's been politicized. If you go to the next slide, and this is my last slide, you know, really public beliefs about the surveillance data and the case numbers and the extent, even the extent to which COVID-19 is a public health threat, you know, I don't know if it's unprecedented, but I have to say, seeing this picture from a Kentucky, local to Kentucky newspaper of graffiti at a testing site, I mean, you know, I mean, it almost seems like an Onion article that you could have graffiti alleging that, I don't know if you can see on sort of the left-hand side, it says PCR test. It's disparaging comments about PCR, and then the other side says false positives, you know, that people feel so strongly that these data are not to be trusted, that even something as straightforward as a laboratory test, that a gold standard laboratory test that is going to tell somebody if they're infected or not, that there is a flat out rejection of even the truth in that. And so when you have that level of potential mistrust of surveillance data, I think you have to factor that into what gets filtered up and assumptions made and calculations made in the models. So I will end there, and happy to take questions later.
Thank you, Jennifer, for a really, really fascinating talk. I think that's going to center the topic for us. Our fourth speaker is Caitlin Rivers. She's a senior scholar at the Johns Hopkins Center for Health Security and assistant professor in the Department of Environmental Health and Engineering at Johns Hopkins School of Public Health. Her research focuses on improving public health preparedness and response, particularly by improving capabilities for outbreak science and infectious disease modeling to support public health decision-making. She is the lead author on the report Public Health Principles for Phased Reopening During COVID-19, Guidance for Governors, which has been used by the National Governors Association, the State of Maryland, and the District of Columbia. Caitlin, please, the floor is yours.
Great, thanks so much. And we've heard a lot from the speakers that came before me, a lot of the key elements of why modeling is so important and where the gaps are. And so I will try to regain us a few minutes by speeding through some of this here. But I think to start with, one of the biggest challenges facing epidemiology is that events keep happening. We feel, and it's true, that this pandemic is particularly unique and occupies a kind of a special place in public health history. That's absolutely true, but we actually have fairly severe events all the time. We had the anthrax attacks in 2001, we had the SARS pandemic in 2003, then there was H1N1 in 2009, Ebola in 2014, Zika, now COVID. Over and over again, we continue to face these threats. Next slide, please. I'll skip this one just again in the interest of time. There's a lot of outbreaks that we do not want to become epidemics, and we don't want those to become pandemics. And so we have our work cut out for us with all of the events that come to pass that we need to tackle. Next slide, please. Now, we think a lot in public health preparedness about medical countermeasures, which are the diagnostics, the vaccines, and the therapeutics that really center our preparedness efforts. But the problem is that, diagnostics aside, we often don't have medical countermeasures when we're facing threats, particularly emerging threats like the novel coronavirus. The research and development of vaccines and therapeutics is difficult, it's slow, it's expensive, and it's not just about the R&D, it's also about the production and the distribution and the entire pipeline that makes it very difficult to bring to bear vaccines and therapeutics for effective public health responses. And that's not to say that we shouldn't care about MCMs or that they don't play an absolutely critical role, but I think it's really important that we also consider all of the non-pharmaceutical interventions and all of the ways that we can inform those non-pharmaceutical interventions, which are the things like social distancing, the closures that we've all come to experience, hand hygiene, these suite of measures that we really have to rely on to get us through the long phase of these events before an MCM can be introduced. Next slide, please. Now, models have played a really important role in shaping public health response, and that's been true for many, many years. In 2014, there was a model put forth by the CDC, and it had a range of estimates, but the very tippy top of the range forecasted or proposed 1.4 million deaths within 4 months. And I've heard that this model was one of the kind of pieces of information that really galvanized the international community to devote resources and to take the West African outbreak seriously when it came to Ebola. And so that's an example of how models can really inspire action and can really inform decision making in a very tangible way that actually does result in this case, a lot of resources and a lot of attention being paid to a very serious situation. Next slide, please. This is a nice figure that summarizes during the 2014 Ebola outbreak how modeling literature was published, the volume of modeling literature published over time. And you can see there was just an enormous explosion of primarily academics looking to contribute to the response by pulling together these models. And it's not just forecasting models. There were also many estimates of the reproduction number. There were scenario models that explored different interventions or looked at international spread. And so there was just an enormous outpouring of modelers and people in modeling adjacent fields looking to contribute. And I think that was really powerful for me to see how much talent and how much ingenuity and care and compassion is out there that we should really be thinking about how best to leverage. Next slide, please. On the other hand, there were also some stumbles when it came to modeling. At one point when I made this slide, if you Google modeling Ebola, some of the first results were highlighting the uncertainties and the things that did not come to pass in models that were produced at the time. And so I think it's important to also acknowledge that when you're modeling an active outbreak, particularly for an emerging infectious disease that we don't know a lot about, there will be a lot of uncertainties and there will be a lot of ways in which models are not right. And that doesn't mean they're not useful, but it can make interpreting them correctly and communicating them correctly a very special skill and a much narrower niche, I think, than how we're currently approaching the use of models in decision making. Next slide, please. And just to summarize that point, this is, again, a roundup of the models that were published during the 2014-2015 Ebola outbreak that compared the projections or the forecasts made in the original modeling paper or modeling analysis with what actually came to pass. And the take-home message is that many of the projections dramatically overshot what ended up happening. And that is, in some ways, good news. It sounds a little funny to say it like that, but I think it is good news because unlike the weather, where it doesn't really matter how we feel about it because we have no control over what happens with the weather, it's really our actions and our interventions that change what happens with outbreak trajectories. And so when we see that we undershoot or observations are lower than what was expected, could mean the model is bad, or it could mean that we have actually affected the outcome and guided the trajectory in a way that's beneficial for public health. And so there is a bit of a balance to be struck there. And again, I think it comes back to careful communication and careful framing of the models and what they're actually telling us. Next slide, please. Now, why do we see sometimes gaps between the models that are created, the models that are shared, and the models that come to inform public health practice? I think there's a couple reasons. One is that the structure of how models come to be produced and fed into the decision-making cycle, it's not really fit for purpose. Right now, most of the models that are produced, particularly to inform public health practice, are made in academia. And I'm an academic myself, and so I have nothing but respect and value for the academic modelers that have devoted their careers to really improving public health and improving the science of modeling. But when it comes to actually feeding those results and feeding those model outputs into decision making, it's not a perfect match because modelers they're not seated next to the decision makers. They're not kind of engaged in the operational tempo of what it means to make decisions during an outbreak. And sometimes, depending on how much experience they have working these kinds of events, they might not have a great intuition of what the questions that need to be answered are and what the timelines of those questions are. That's something you really gain with experience. And for people who sit full-time in academia and may not really engage with decision makers regularly, it's not obvious often how those pieces fit together. Next slide, please. And Dr. Nuzzo really laid out very nicely that what goes into models is data. And if you don't have good data, then it's going to be very difficult to produce high quality models. And it's a major problem that we need to address, particularly in outbreaks where we know that the data are often messy and inaccurate because they are chaotic situations, often in under-resourced settings. And so this is a perennial problem with outbreak modeling. Next slide, please. Again, in the interest of time, I'll fast forward. Next slide, please. Just one quick case study on that. During the 2014 Ebola outbreak, there were a lot of problems with the outbreak data. Again, it was an under-resourced setting. It was a chaotic situation, as all outbreaks were. And so at the time, what each of the affected countries was publishing a PDF situation report that had this very high-level information about the number of new cases and the number of deaths. And often, not often, occasionally, but enough to be a problem for modelers, the data were a little bit nonsensical. Like the numbers would go down when it was cumulative and only should go up, or you would see changes in the way that data were reported. Suspect and probable would be merged and then they would be unmerged. Again, from this perspective of a public health practitioner, probably very sensible reasons for why that unfolded, but can really be a problem for translating that data into models. Next slide, please. But I think one bright spot, one challenge that we did not have in Ebola with the data is that all three of the affected countries were using the same case report form. So they were collecting the same information on everyone who was sick with Ebola. And that made it possible to compare across jurisdictions, not just nationally, but also within, like here in the United States, each state and sometimes even each county is able to create their own case report form and really decide what data they want to collect. And that makes it very hard to compare across jurisdictions. And I think that can be a really big gap. But it's not a challenge we had during Ebola. And I think that there's a great lesson there of the value of standardizing these case report forms. Next slide, please. So how do we get better? I kind of whizzed through the challenges, but I think the previous speakers, my co-panelists, have done a great job of laying out some of the challenges. I think how we get better is to continue to invest and continue to create the systems and structures that will allow us to achieve our vision, my vision that I will share with you, of what a really successful operational forecasting capability would look like. We did this with the National Weather Service over time. You can see on the plot here that in the 50s, we weren't very good at forecasting the weather. It's a hard work and we weren't good at it. But over many decades of investment in data collection instruments like satellites and in supercomputers to help to support the analyses, we were able to get forecasting skill to the place that we enjoy it now, where we have fairly good accuracy and confidence in those forecasts. And it was not by magic, and it was not a random walk through improvement. It was sustained investment in a vision of having accurate web forecasts. And we started from that vision and we figured out what we needed to do and the steps that we needed to follow in order to achieve that vision. And I think that's where we need to be with infectious disease modeling. Next slide, please. All right, I'll end on this slide. What I think would be a great final vision for a capability, a national capability to do something like the National Weather Service, but for infectious disease forecasting, is to create something that could notionally be titled a Center for Epidemic Forecasting and Analytics. There are really no other capabilities of strategic national importance, capabilities that we make multi-trillion-dollar decisions on, like we have made multi-trillion-dollar decisions like we have made during COVID, that we don't have a national formalized capability for. We don't do it for the weather, we don't do it for the military. For all of those important functions, we have national centers that are and national institutions that are tasked with doing that important work. And so I think we need to have something like that for models and forecasts. During peacetime, this notional center could develop the models and the processes to produce forecasts and analytics. They could take the best of what's happening in academia, all of the amazing innovation, and really figure out what works best for outbreaks and what is most supportive for public health decision making, and make sure that the models and the processes are really fit for purpose, so that when there is an event, we have everything teed up to be able to bring the best to bear. And then when there is a public health event, this center could support decision making at the federal levels, but also at the state and local levels, and make sure that those decision makers have what they need in order to guide those decisions well. Again, we have spent trillions of dollars, or both spent and in terms of missed economic opportunities, based on this pandemic. And I think if we were able to bring to bear more data and more analyses, then we could, in future events, hopefully limit the impact both to morbidity, mortality, and economic impact. And I also see an important role for this center to communicate with the public. We all have weather forecasts on our phones and on our TVs that tell us what's happening in our communities so that we can really make individual decisions about whether to bring an umbrella or whether to cancel the soccer game. And I can imagine a future where we would have something like that for infectious diseases. It could do seasonal influenza. And if we were, for example, because that's something that we need every year, but then when there is one of these major events, we could also bring the data closer to individuals to help them to guide their decisions and to keep themselves and their families safe in that way. And because data is such an important aspect of modeling and analytics, there are a number of great data modernization initiatives and ideas in the pipeline. And I think the center would be best served by supporting those existing initiatives that are underway, like the data modernization initiative that is being pushed as a wonderful effort by some of the public health professional associations in partnership with the CDC. I think that's absolutely critical, and I would like to see that go forward. Again, just because if you don't start with the right materials, it's really hard to make models be their best selves. And so I think that's absolutely critical. And I do have more slides, but I am going to end there. Thank you for the opportunity.
Thank you, Caitlin, for a fascinating talk. I would like to come back indeed to this suggestion for a national center. But also I really appreciate how you sped up and indeed helped us to deal with the problem of time. Our final speaker is Jeff Shaman. He's a professor at the Department of Environmental Health Sciences and director of the Climate and Health Program at Columbia University Mailman School. He studies the survival, transmission, and ecology of infectious agents. His work to date is primarily focused on mosquito-borne respiratory pathogens. This is kind of old because I think we all know Jeff by now for the work on the COVID and some of the stuff that has been published in the New York Times and elsewhere. So Jeff, please, the floor is yours.
Thanks, and thank you for having me. This has been a fascinating discussion. Because I sense that we're supposed to end at 6, I'm going to actually keep my comments very short so that we can actually have some Q&A. And a lot of the territory has been covered by the preceding speakers. I just am going to make 4 quick points. One is that when you look at the scientific inquiry process, one of its main objectives, of course, is to understand the world around us, to understand the phenomenology, how things work, what makes them tick. But a fundamental tenet of that we sometimes lose sight, and I think a lot of scientists lose sight of, is the ability to predict things. To predict something out of sample, and particularly in the future, is a real testament to your ability to actually be able to know the system well enough to say something sensible about it. And it is a goal that we need to aspire to in many fields that we haven't yet considered. I would say that you think about the fundamental physics you might have learned in high school. You hold a ball a meter above the ground and you predict how long it will take to hit the ground because of gravity. That's a prediction. It's the ability for a microwave to reproducibly do things when you press the buttons on it. Those are all systems for which we've constrained our understanding well enough that we're able to make predictions of how it will behave in the future with certain levels of certainty. The certainty brings up the second point, which is that when you look at predictions in some fields, particularly those that are nonlinear and chaotic, they get really out of hand really fast. Some of the speakers have pointed to weather considerably, and that's a really great example of how we've been able to actually develop skillful predictions of the future based on our understanding of the system itself and its nonlinearity, its chaotic behavior. Infectious disease forecast has the same issue. And I think it's important to think of forecasting output as just part of a continuum of information, an information stream, if you will, that begins in the past with observations. It comes up to the present where you often don't have complete observations of the system because they haven't yet come in or been finalized or been reported. And we often have some statistical methods to try to estimate it. It's sometimes called nowcasting. And then it extends into the future with forecasts that try to predict what will the outcomes look like, what will the future hold for us. Now, associated with all those pieces of information, the observations of the past, the nowcast of the present, and the forecast of the future, are uncertainty. That uncertainty, as people have talked about previously, tends to grow as you go from the past to the present and into the future, so that forecasts generally have more uncertainty than observations of what's happened in the past. But as also has been highlighted, that's not always the case. There are some very good forecasts that you can make even in infectious disease. And certainly for some other systems, we have much better forecasts, dropping a ball a meter above the ground. And there are lousy observations. There are observations that come in where we know the observational system or framework is not reliable. And so we have to actually account for the uncertainty surrounding all those pieces of information and recognize that uncertainty plays a factor in the past observations as well as the forecasts of the future. And we have to put that all together whenever we're making use of it. And any judicious use of this information, be it a past observation or a future forecast, needs to account for that uncertainty. And it's really the job of science to try to reduce that uncertainty, to tame it and make it so that we have more certain information to use and utilize to better people's lives. I think the third piece of information Dr. Rivers just covered, which is that we have to understand that investment in this work, investment in infectious disease forecast, will lead to improvements. As a matter of fact, infectious disease forecasting for systems in particular like influenza and other respiratory disease has advanced considerably over the last decade. And it's because of investment in it. And continued investment in it, and a government-style center such as Dr. Rivers is proposing, would be a framework for continuing that investment and getting us to a better place, where we improve our observational frameworks, we improve our forecasting models, we improve our post-analytics and post-processing of forecasts, and we improve the communication of these forecasts and their end use for people like you and me. And that lastly brings me to the fourth point I wanted to make, which is consumers. Whenever we're delivering forecast information or observations or nowcasts, we have to know who we're talking to, and we have to tailor the message to the people and their interests. We have to tailor to the level of understanding they have, the use they're going to use it for, and how much scope they want in it. This is something that a number of people have spoken about already, but it's a critical component in order to actually show the utility of forecasts and actually to frame the information appropriately so that people can understand it and utilize it in a sensible way that isn't going to be erroneous, isn't going to be flawed, and will actually improve their lives in the case of this disease outbreaks. All right, I will stop there. Thank you for your time, and I'll turn it back over to you, Gil.
Thank you, Jeff, for giving us a brief view, but probably you will get questions, so you will be able to speak a little bit more. Matt has told me that he has a hard break at 6, and as a result of that, I'm going to tweak a little bit the order of the questions. The first question there that was upvoted is actually for Scott, but I'm going to have a couple of questions first from Matt, and then see where it goes. So there was a couple of questions here from Matt. I'm going to read both of them, Matt, so you can take the last time that you have to answer them. The first question from Ale is, question to Matt, which may be also meaningful to later speakers. Is there a person at the CDC whose job is to investigate the interpretation and trust issues people are having with the published information and act on that? Or are the choices of what and how to make things transparent coming from researchers' expectations of how it will be read and what will matter to people, journalists, etc.? That was one question for Matt, and I'm going to read the other one because I think it's related and it's short. Question to Matt. How has President Trump's decision to funnel COVID-19 data from hospitals, I believe that's a decision not to have it go to the CDC first, in July affected your models?
Thanks, and sorry, I'm flying home tonight, so my flight's at like 7:20. I can't stay much longer, so apologize for that. I'll be quick with those questions. So the other panelists, I think Caitlin also has a hard stop as well. One about sort of, are there people sort of trying to look at the websites and understand how the messaging that's going out or the information that's being put out is impacting trust? I mean, we have a huge group of people at CDC who are really monitoring Twitter, other sorts of avenues that people have to kind of express their sentiment, seeing what the reactions are in the media to what goes up on the website, seeing how that message is getting disseminated. That is a very active part of the response at CDC. So there are definitely people doing that, and chances to sort of refine messaging as we go along to really understand what is working and what isn't working, and what do we need to do to make communication better. And that's something you've seen with forecasts. We were trying to evaluate our messaging over the time, and then multiple other groups that are putting out guidance, our notifications are doing that as well. For the second question about the hospital data, you know, I think that actually has a chance to help. I mean, I think before that decision, there were still disparate places people could report this data, which I don't think was actually reported well in the media at the time. It wasn't like NHSN was the only system that could be used to report. These other approaches were ways that could be used to report information, and it just was sort of a decision to take it down from 3 to 2, and that at least made it going into one data set, and potentially was trying to get people to report into one framework, which wasn't occurring. And it's sort of, CDC is actively trying to then work in that space to improve the data quality, which is now on the HHS Protect Public website. And that was an effort that was going on when NHSN was doing it. So I think there was a little bit of communication around that sounded like CDC was being taken out of the process. That isn't true. We are actively still working on those data sets. Part of the team I'm in DC with is working on that. So thanks.
Okay, I should have said also for the other panelists, you can unmute yourself and jump in if there is a question that you also want to address. Caitlin has also told me that she has a hard stop at 6, so Scott, please hold off for a second. I will get to your question. And I actually had a question to Caitlin because she had this idea of sort of a national center, and she suggested for us the model of weather. And other speakers have also talked about it, but I wonder, Scott can also come back to this issue, I wonder how much this is similar to weather prediction. And the big issue for me is reactivity, namely the reactivity of what you measure to your measurement. In weather, the storms don't care about what we say in terms of forecasts. But an epidemic is not just a virus, right? It's how people behave. And they read about the models secondhand then or whatever, and they react to them. So it seems to me like a slightly different problem here. That's a question for you, Caitlin, and anybody else can jump in on that.
Yeah, I think that's right. And just to give credit where credit is due, this idea has been around for a long time, and I'm currently the sort of keeper of the driver of the idea, but there are, including people on this call who have contributed as well. But I think it's right that behavior, we do change the outcome. Behavior changes the outcome of outbreaks. That's exactly what we want. That's really the whole point. And I think that there's a lot more research and science that we can do about how best to incorporate those behaviors, both observationally and kind of looking forward and expecting how behavior will change into our methods. I think there's ways the science can grow. And I think there's also more we can do. Dr. Biggerstaff mentioned in his presentation that CDC prefers to cap their look-aheads to 4 weeks, because that is kind of the interval that is most appropriate. Mm-hmm. And I don't think that we see all modeling groups making that choice, but we probably should. And so I think also a better understanding of the limits of our models and making sure that we stay in an area that is defensible is also a reasonable way to kind of approach these uncertainties.
Right. Anybody else wanted to jump in?
Sure. I mean, I completely agree with Dr. Rivers. And I think there are lots of good analogies to weather prediction. As I said, the systems are nonlinear. We use some of the same methods to bring to bear to actually generate the forecasts, but there are some critical key differences. There are different things that we actually have to estimate on the fly when we're trying to make an infectious disease forecast. And as you've been discussing, the non-pharmaceutical interventions that we're imposing, particularly here for COVID, have had a decided effect. How we behave is affecting the dynamics of transmission of this disease. And that's very hard to predict. And that actually takes it from the space of forecasting, I will argue, and I've argued with lots of people about this, to about projection, which is that in order to make any prediction of the future here, we have to assume what behavior will look like. And I completely agree with Dr. Rivers that 4 weeks out, maybe 6 weeks out, is really as far as you can go with this disease, because so much of what will happen depends on what the public and our political leaders do in that time period. That's going to set the course that we follow. So projection to the end of the year is just speculative. It shows us what might happen in a very, very cursory way and provides guide rails as to what might happen. That in and of itself can be important, but it's very important to contextualize what is an actual projection and a forecast, and how can you distinguish all those things. So there are some big differences there, but wouldn't it be great if we had forecasts that we were making that are accurate, and then people acted on them and they changed the outcome of the outbreak? We could show that happened. That would be a wonderful outcome to actually ultimately have if we can get that kind of precision and that kind of responsiveness from our society.
I'll just say, I mean, just one thing to chime in, and I agree with the need for these efforts and really support, getting us to that point. I think one difference with the weather, and I think this is important for thinking about incentivizing this work and making sure it's sustainable, is that, we monitor and try to make forecasts about the weather because there's commerce at stake, the ability to move goods and people, and there are clear industries that rely on having accurate information and not proprietary information in order to be able to act upon. And I say that only because I don't think we've yet ascribed that kind of value to public health information. Clearly, I think the pandemic right now is showing the enormous economic tolls that not having that information can have. But I think prior to this event, it was probably less clear to people. And when you've seen, an erosion of public health capacities throughout the U.S., when you've seen, outdated surveillance systems never be updated again, it's in part because we haven't yet ascribed value to this. And I if I have one hope, it's that I hope that this event will change that and have people see that there is more than stake than just, lost lives, which we seem to tolerate.
Could I add a little bit?
Please.
Sure. So just a note about what's been said. So it certainly is very important that you can't influence the weather, but you can influence an epidemic. But that being said, I mean, most of us on the call from the very beginning of COVID, we modeled different scenarios. So one scenario, people didn't change what they did. The other scenario, people changed dramatically what they did, and all sorts of ones in between. And so that certainly is something that most of us did, and most of us, I think we were able to communicate well. But even within any one of those scenarios, the probability issues are still very much there. There's a lot of uncertainty, even if you think you know what people are going to do, above and beyond the issue of whether you influence it. And so it is, I think it's important not to have an implicit exceptionalism with regard to health being different from every other thing. It is different, but to have that as an automatic default, I think is dangerous.
Mm-hmm. Okay, and there was a question for you, Scott, and this is from Ryan. And Ryan, I apologize because I could see that your question was very close to mine. I read it nonetheless because there are some other different aspects to it. Ryan's question is, Scott includes both weather and financial market forecasts in his list of other domains that pandemic modelers might learn from. Do we think pandemic forecasting will improve to the extent that weather forecasting has? Incredible improvements in hurricane track forecasting in the last decade? Or is there a limit to how precise pandemic forecasts can get, given that they are to some extent performative, the way financial models are, but which weather models are not? Does precision of pandemic forecasting depend to an extent on whether or not they're modeling the spread of a new pathogen versus one with which we have extensive historical data?
Oh, right. So what a great question. I agree with Caitlin that a substantial investment in infrastructure could yield improvements. And when Caitlin was showing that graph, keep in mind that things got better, but they weren't great. They're better compared to how they were. So I don't know what the natural limit is. If there is a limit, and if so, what it is with regard to how good the forecasting could be. I'm really not sure. But my personal belief, this is just merely an opinion, is that we could see advances of the magnitude improvement that we saw with weather.
Mm-hmm. Anybody else wanted to jump on this?
I can think you can make one distinction. There are hard limits of predictability associated with weather that are in the span of 14 days. You'll see some agencies like AccuWeather make 45-day forecasts, but it's completely bumped at that point. The limits of predictability are mathematically derivable because of the nature of the nonlinear dynamics of the atmosphere. Disease systems, as we represent them, tend to be less nonlinear, and that has allowed us to make forecasts farther into the future. Instead of 2 weeks, we can do it months into the future. And so that is one distinction that's there that's also interesting. So exploring that at different scales is going to be something that's going to be very interesting to go forward with. But I agree with Scott that it's not clear where the limits are for this. There's a lot to be done to explore it, and there's a lot of room for improvement in delivering information, observations, nowcasts, and forecasts in ways that can improve people's lives. And as Dr. Nuzzo pointed out, integrate it into our economy so that we can keep other things going as well and integrate health in an appropriate, sensible way.
Okay, we have, we're over time, but in case you guys can hang out, there's still more questions. There's a question by Hadija. It's not indicating to whom, so anybody can jump on this. Can you speak to data aggregated by race for COVID-19 and particularities of disproportionate infection among incarcerated people when the sole source of data collection is from the Department of Corrections? And what can be done to better communicate models of infection in communities who lack trust in studies, testing, and treatment? So really 2 questions.
I can chime in on that because that's been a focus of ours on the testing site and the case sites. It didn't show. We also, on this Hopkins site, have a US map with county level data. And one of the things they did early on was try to identify the states for which racial data breakdown of the case numbers were available. And first of all, that number is not complete. Not all states share case data broken down by race ethnicity. Since efforts to track these data and with intense, I think, public interest in these data, more states have made these data public as similar for other outcomes. So we've been tracking testing since the spring. The number of states that are actually now sharing more transparently their testing data has increased. And so I think this is an important thing to do. I mean, I always say in an ideal world, we don't have to do this. This is what states and governments do, but nonetheless, I think the push for information has prompted the availability of more information. That said, it's still by far not complete. So while even in states we may get a breakdown of cases, we don't really have a breakdown of testing to understand if there are systematic access issues. Mm-hmm. There are reports that there are access issues in terms of testing. You can imagine a variety of social factors that could influence that, but we don't really have those data. And so that's just something that we are continuing to look at and trying to push on as much as we can, and have some some analyses kind of that we're working on right now that will hopefully speak more to that. In terms of corrections, same issues. There's not a lot of transparency, if you even want to call it that. That term I think is really loaded. I just mean that those data aren't really available, and some of it is related to process. So I heard from reporters in some states that a Department of Corrections was going through and trying to test every single one of its inmates. An enormous endeavor, enormous cost. But it's a one-time test, which if they were negative that day, that all we know is that they were negative that day. And so, we just don't have the surveillance systems we need to understand what the drivers of transmission are and to try to understand how, where our problems are and have to intervene. One thing we didn't talk about today, which I am hopeful for, is another category of information. It's not technically surveillance, but contact tracing. And the extent to which we investigate cases and try to understand where they might have been prior to becoming sick, that can make us better understand trends in a kind of sample-based way. And that, I think, when it comes to racial data, but also things like congregate settings like correctional facilities and nursing homes, I think that the extent to which we can get more contact tracing data out in the public, the more we'll be able to understand and improve our surveillance.
I would add that, you know, we're stuck with a partial view of the system. It's very incomplete. And on many dimensions, we don't have the levels of information that we would like in order to really understand what's going on. And we would like to understand the system as rapidly as possible, because the better we understand it, the better we're going to be able to control it. And this has been a persistent problem in health and in infectious disease for a variety of reasons that we could spend hours talking about. Certainly, there have been lots of studies into the health inequities associated with COVID-19, how it cuts across socioeconomic lines, how it cuts across gender lines even, how it moves through demographic lines, in particular age, and how it's unduly affecting communities of color. But that doesn't mean that the data are there. People have to dig for them, and it's not routinely available. And it also goes for the incarcerated populations as well. It's been really interesting to see the studies that have come out and how much this whole pandemic has brought, once again, into relief the disparities in health access and healthfulness that exist within the United States. And it's a tragedy, and it's a travesty, and it's ongoing. And hopefully this will motivate a little improvement in that, if not a lot.
Okay, we have a question from Seth. There was a debate. Oh, sorry, Scott, you have to go.
I do have to go, but thank you very much. It's been a pleasure.
Thank you. Thank you for joining us. There was a debate earlier this year about the availability of an influential model's source code. When the code was released, the quality of the code was called into question. This criticism was significantly driven by scrutiny from shut-down skeptics outside the modeling community. My question: how should modelers navigate demands of openness, given the fact that models are never perfect? And may I add, there are people lurking out there to find, you know, even quasi-problems, right?
Well, you know, look, I think there are a number of issues here. I am a believer in making your code public, letting other people play around with it, let them find the flaws, let them find the errors in it. And there always are. We're human and we make errors in it. And you just hope that you vetted it well enough that any of the errors in there are very minor and inconsequential to the results that you're actually producing. That's hard to do. And I have to say that if you go into forecasting where you're doing it in real time, you're out there without a net, so to speak. So you're kind of used to putting out information that can be evaluated as to whether you're right or wrong. I would say in the flurry of the activity associated with this pandemic, there are a lot of people making projections all the time and laying out numbers, and there's a very prominent place out on the West Coast that does this constantly, that nobody bothers to stop and go back and say, well, how good was it? We haven't been checking it so much. And again, you know, they're not really supposed to be forecasts because so much is dependent on what we do. But being able to put your information out there and say, I've made this prediction, this is what I think is going to happen, I think this is the truth. If you're doing it as a real forecast, then you're putting your money where your mouth is, you leave it out there and you see how well you did. That's akin to also making your code open so people can see what you're actually doing to generate those forecasts. Now, certain entities may hide behind privatization and proprietary demands, and that will be a problem in many instances, particularly if you start to see the privatization of infectious disease forecasting. But there has to be, at least under the academic and government communities, and willingness to be open and share the code so that people can learn from each other and correct each other and keep everybody honest.
Jennifer?
Not much to add on that.
Okay. One last question.
I agree.
Jennifer mentioned the need for comparable surveillance. This is a question from Ale. But standards and collaborations take time to structure, same for transparency, and trust takes time to build. It seems unlikely that these things to be timely and successfully set up in response to an emergency. So what are the options and challenges? Part of the work definitely fits within current trends to open science, but it also has complex specific requirements. So for example, could institutions establish collaboration practices in advance, perhaps continuously?
So maybe just speaking a little bit about data standards for public health surveillance in the US, because I think when we talk about it globally, that's a much harder, bigger topic that gets into national sovereignty and also national capabilities. But let's take the easy problem of fixing surveillance in the United States. I mean, we do have a process by which this should happen. You know, typically the US Centers for Disease Control work with the Council of State and Territorial Epidemiologists, and then they jointly, I mean, I think most people probably don't understand that surveillance for infectious disease in the United States is a purely voluntary process. But it is done, it is achieved, it is gotten to because people see value in it. The states want to know not only what's happening in their own state, but what's happening elsewhere in the country so they can compare themselves. And they recognize the need for data standards like case definitions. And so that has happened to some extent in COVID-19. But in my belief, it hasn't gone as far as it needs to go, and frankly, as far as it would normally go, in part because of the politics of this moment. And it's true, it's really hard to force it, particularly when the political scrutiny is what it is right now, where, since we started tracking testing, for instance, states initially responded by dumping in a whole bunch of tests into their numbers to make their numbers look better. That eventually gets found out, and change has been made as a result. I can tell you, one of the things we track is test positivity, and I can't tell you how many angry calls we've gotten from states that are mad that the way we track positivity isn't the same as the way they do it. We take a 50-state solution, so we kind of have to do the best calculation we can to allow use of all the data that's available. But the absence of data, consistent data in each state, makes it hard to come up with the same estimate for each state. And they're mad about that. They're really mad about that. I'm hopeful that anger will translate to data standards because they're now seeing the consequence of not having it. So yes, it's hard, but I don't think it's impossible. I think we're moving towards it. And I think pragmatism, the need to not find your state on a quarantine list of another state, will possibly force the issue to greater standardization of the data that's being put out there.
Well, I mean, but if you were a U.S. agency, a center like Caitlin suggested, then this would not be just angry calls. It would be we might cut your funding, So I wonder. Yeah.
And I have to believe in another time that's what would have happened, but I think the politics of the moment are unfortunate. It's just what it feels like.
But I would also note that, for instance, the CDC is not a funding body. They have very little sovereignty over local county level health agencies.
It's true.
So it's very difficult to get them to play ball. So in some sense, the US is a bit of a microcosm for the troubles that you would also have that get even worse due to less trust and less communication and less practices and less funding once you go internationally. It can be a real mess. And that really does compromise our ability to look at it in a global perspective and really understand it. People have suggested, why don't you have a global model for flu? And some people do try to do global models for COVID. And just for flu, it's a disaster. They use completely different measures to estimate what is going on with flu. So you can't move from France to Germany without running into problems.
Okay. I'd like to thank Jeff and Jennifer and all the other participants. I think there are still 25 people on the call, and this is after we went 15 minutes over time. I think that's a record. That's a testimony to how informative this was. So thank you again for participating in this, and hopefully we could see you maybe as audience in our next iterations.
Please do.
Thanks for having us.
Thank you so much. Appreciate it.
Thank you to the audience as well.